So I want to ask you something. So I think knowing the piece one and the ARISEN study is very critical. Also, when you were talking about those studies, especially piece one, it brought up a question I don't know if I've asked you before, because you said there's this group that gets radiation too, right? And you don't know the results yet, right? And so the idea brings up the idea of cytoreductive procedures and debulking. The idea here is that when someone has advanced disease, it's gone beyond the prostate, metastatic, there's still viable tumor potentially in the prostate itself. And so the question is, where are we with that now in terms of someone having metastatic or advanced disease and still going after the primary tumor in the prostate, for example? Where are we with that? And where do you think it might go? Because I know it's not clear, but where are we with that, and where do you think it might go?
That's a really, really good question. You're so good at asking the salient points, the relevant points. So where we're at right now with radiation to the prostate for somebody who has already advanced metastatic incurable disease is this. Number one, and there's good theory behind it. There's a bunch of retrospective studies where people have looked back at patients who had metastatic disease and got local treatment of the prostate, and they seem to imply benefit, but you have to be careful with retrospective series because there can be bias introduced and unknown kind of selection bias in the patients that were looked at. So the only way to really prove something in a clinic is to do a well-designed randomized prospective clinical trial, which has been done. So let's talk about what's been done. So the first study that read out is the HORAD trial. Took patients with metastatic prostate cancer and randomized them to get radiation or no radiation to the prostate in addition to standard therapy, which at the time was hormonal therapy, androgen deprivation therapy. That was flat out negative. There was no benefit to cytoreduction or reducing the tumor burden in the prostate, and that's just probably because those patients had really high PSAs in that study, really high volumes of disease. It was all over the place for most of the patients in the study. And so one could argue that treating just one spot when you got a whole lot of other spots probably isn't going to lead to benefit. All right, so that's negative study number one. Study number two. This was the STAMPEDE study, and I keep bringing up that name over and over again because it's a UK study with 1 million arms, essentially. But in one arm, they did radiation. And in that study, for the overall analysis of people with metastatic disease, there was no benefit to adding radiation to the prostate. Negative study number two. Now, however, in that study, the STAMPEDE study, they had a subgroup analysis, and it was pre-specified, meaning they planned to look at it. And they mentioned it in advance that we're going to look at it and statistically analyze the low-volume subset. Because their theory was, maybe it doesn't work for everybody, people with lots and lots of disease. But if you have maybe limited disease, 1, 2, 3, 4 spots, and we reduce that tumor burden, maybe that'll lead to survival outcomes down the road. Okay, just less spots there to be active, to mutate, to become nastiness. Okay? And that subgroup analysis was positive. Okay? So, this has led to a lot of, I think, differing opinions in the field. I think there are a lot of radiation oncologists who think, hey, that's a done deal. There's a study that's positive. I can irradiate it. I can. Yes, I will. Go to a barber. You're going to get your hair cut, right? So you go to radiation oncologists. They're familiar with that data. You got low volume metastatic disease. You're going to get radiation. Some of my medical oncology colleagues, I'll just tell you, my group here, there's 10 of us that are GU medical oncologists. I think there are 2 or 3 that feel very strongly, at least 2 that I can think of, about radiating the prostate or at least offering it to patients. I'm one of those who are like, well, 2 negative studies overall, 1 positive subgroup analysis. That's not definitive for me. Do I ever offer it to patients? I talk to patients about it. But I don't encourage people to do it. If people hear about it and said, I'm okay with 2 negative and 1 positive subgroup, I want to do it, I'll refer the patient to a radiation oncologist. But what I will tell people is that there's more data coming. And that data comes from piece 1 that we talked about. And that data will also come from a study called SWOG 1802. And the reason I like SWOG 1802 is this. is SWOG 1802 is a study where people get randomized with metastatic hormone-sensitive prostate cancer to standard systemic therapy, which is essentially androgen deprivation, and you can add abiraterone or enzalutamide or docetaxel. It's whatever you think is reasonable standard, which I think is with treatment intensification. You can even do androgen deprivation therapy, docetaxel, and darolutamide now. Or that standard systemic therapy plus treatment to the prostate. And the reason I like it is treatment of the prostate can be dealer's choice, up to the patient, up to the providers. And that dealer's choice can be surgery, and that dealer's choice can be radiation. Now, the reason I like that is when you look at Stampede, they used an unusual radiation schedule. They didn't give full doses of radiation. They gave lower doses of radiation, and not necessarily daily radiation like we normally do. But in SWOG 1802, people were going to use standard higher doses of radiation. And so one has to ask, maybe that'll lead to better outcomes. And maybe having surgery in there could lead to better outcomes as well. So in my mind, the jury's still out. If I have a patient that's interested in this topic, willing to explore it, and willing to undergo randomization, I would encourage that any day of the week, because I think we don't know the definitive right or wrong answer yet. And in that situation, what better than enrolling on a clinical trial? Because not only are you going to help, is that knowledge going to help contribute to science in the future and help other people, but maybe you get lucky and you get the right treatment too. And I always tell people that when you go on a clinical trial, if we knew what the right answer was, we'd already tell you to go on it. The reason you're going on a clinical trial is this is promising, but we don't yet know what the right or wrong answer is. And the number one reason to do it is you're an altruistic individual. That knowledge, whether it's positive, negative, whether it's good, bad, whatever, that's going to help a lot of other people down the road. A lot of my patients, they have sons, they have nephews. They're thinking about others with prostate cancer. They want to do it. But as a side effect, as a side reason, maybe you'll get lucky and you get a treatment that's very beneficial, and they'll help you before anybody else could get it as well.